Thank you, Mr. Naslin. So hello and welcome everyone. This is Caleb from TASC at the National Rural Health Resource Center. Today is Wednesday, May 12th, and this is our May TASC 90 webinar focused on supporting new models of payment and delivery. And following updates from our partner organizations like the Federal Office of Rural Health Policy, as well as RQITA and Stratus Health and the Flex Monitoring team, we have today with us George Pink from the Flex Monitoring team, as well as John Supplett from the American Hospital Association to provide some updates and information regarding some of the new models and related to payment and delivery. And then we, as always, have time for questions and discussions following the presentation from John and George. I see Tori is here. So Tori, if you are ready, I will give my updates that I have and let Andy get our polling questions started, and then we'll kick it over to you for our update from the federal office. So I have a bunch of webinars. The first thing I'd like to bring to your guys' attention one more time is the RIPT program. We have a learning collaborative starting soon, and this is focused toward your guys' hospitals, not to Flex programs specifically. It's designed to help assess organizational strengths and weaknesses in preparing for the transition to value-based care. So if you have any questions about that, please do let us know, and we can get you the information and your hospital the information needed for that. The registration for the reverse site visit will be opening soon. Toward the end of May is our goal, and that will be held virtually again, July 20th to the 22nd. We have a telehealth webinar series continuing. Our next webinar for that will be on May 17th, and that will focus on virtual primary care, and that is 2 p.m. Central Time. Our June Flex Virtual Knowledge Group call is scheduled for June 15th, and the topic for that virtual knowledge group call is non-traditional partners. So we're thinking beyond the hospital association and your local public health entity. So if your Flex program partners with new and interesting partners that others might not be thinking of, please do reach out to me. We will have something in the Flex forum for you guys to respond to as well. Jill is asking if we can have more than 2 people on the virtual site visit since it's virtual. That is a good question, Jill, and I will ask anyone from TASC who knows the answer to that to answer it, or we might have to get back to you if we don't know the answer right now. Let me go back to my update screen. We have a new guide coming out, and that is related to implementing and sustaining rural community paramedicine. That is expected to be released June 16th on a webinar on June 16th at 2 p.m. Sorry. And following the May 17th telehealth webinar series, the next meeting of that will be on July 7th. And that will focus on telemonitoring of rural patients. Again, that will be July 7th. And Tracy, thank you for responding to up to 4 per state is what we can allow at the virtual reverse site visit. And yes, to be clear, up to 4 state Flex program personnel per state are invited to attend the virtual reverse site visit. Thank you for that. I believe that is all of my TASC updates, but if I'm forgetting anything from the TASC team, please do send me a chat and we'll get it updated. Tori, if you're ready, we'd love to hear some RHP updates.
Thanks so much. Hi, everyone. Just my biggest update is that your Flex NCC is due Friday, May 14th. This also includes the submission of your Flex Quality Improvement Project proposal under attachment number 3. Please reference the TASC website for all updated guidance information, and please reach out to your project officer if you have any questions or concerns. I'll yield my time to Craig.
Howdy, Craig, and welcome for a regulatory update from the federal office.
Great. Thank you so much, Tori, and thank you for having me for the May update. I'm going to try to, cram in 4 topics in 5 minutes. I guess Tori yielded some more time to me, so I guess I don't have to speak as fast as I had planned. But the first thing is the inpatient prospective payment system fiscal year 2022 proposed rule came out in late April. And I just want to talk about a couple of the graduate medical education changes that CMS is proposing that address some of the Consolidated Appropriation Act of 2021 provisions. The CAA section 126 was addressed by CMS at CAA section 126 made available 1,000 new Medicare funded GME graduate medical education positions over a 5-year period, so about 200 per year. CMS is proposing 2 alternative methodologies for distributing the slots for a maximum of 1 per hospital per year. The first alternative that CMS is proposing is that residency positions would be distributed with the priority based on HPSA scoring alone. So the proposal is straightforward, but it just focuses on HPSAs as the basis for slots. The second alternative that CMS is proposing to distribute the slots is to start with fiscal year 2023 and distribute the 200 slots for that year according to 4 categories of hospitals. First, hospitals in a rural location. Second, hospitals above their current cap. Third, hospitals in states with new medical schools or branch campuses. And fourth, hospitals that serve HPSAs. Higher priority would be given for hospitals that qualify in more than 1 category. So in theory, the highest priority would go to a hospital that met all 4 of the criteria. This alternative would provide more time for CMS to develop proposals for future fiscal years because it's just for 2023, and then CMS will gather more information. The proposed rule also addresses CAA, Consolidated Appropriations Act, Section 127, which made statutory changes both for urban and rural hospital full-time equivalent resident limits for the graduate medical education payments for training in accredited rural training track or RTT programs. CMS is proposing that rural hospitals can increase the RTT full-time equivalent caps. The goal of this proposal is to close the rural urban health equity gap. And comments on this rule are due June 28th. Second thing I want to talk about, and I'm going to be sending Tori a bunch of links to what I'm talking about today, so you'll have more information after the meeting. The second thing is the latest hospital star ratings that were released at the end of April. In February, you may recall that I summarized changes to the hospital star rating methodology from the OPPS calendar year 2021 final rule that came out in December. The results of applying the new methodology, the new hospital star rating methodology for the first time were included in a Modern Healthcare article that came out at the end of April. The results were that nearly 1/3 of all hospitals scored higher ratings, 45% at about the same ratings, and about 23% did worse. But if you look at the critical access hospitals alone, they didn't fare as well. Under the old methodology, 94.3% of critical access hospitals received 3 or more stars. Under the new methodology, only 76.3% of critical access hospitals scored a 3 or more, according to the Modern Healthcare study. And for the average star ratings, critical access hospitals average decrease from 3.83 under the old methodology to 3.23 under the new methodology, and compared to medium-sized community hospitals, which increased from 3.1 to 3.29, and teaching hospitals, which also increased from 2.83 to 3.16. So the averages are more clustered together now. The third thing I want to talk about is the on May 7th, the CMS released an interpretive guidance on the conditions of participation, or COP. Requires hospitals, psych hospitals, and critical access hospitals with electronic health record systems to send electronic patient event notifications of admission, discharges, or transfers to other facilities or providers with the consent of the patient. Hospitals that lack such an electronic records system aren't required to be in compliance. The COPs are effective as of May 1st and were finalized in a final rule that just came out, and are addressed in recently released frequently asked questions document that I'm going to send to Tori. And finally, the fourth thing and final thing I want to talk about is the new fact sheet on Medicare waiver for ambulance treatments in place was just released by CMS. CMS describes circumstances for ground ambulance services to be reimbursed by Medicare for treatment in place because a patient couldn't be transported to a destination that is permitted under Medicare EMS protocols due to the COVID-19 public health emergency. The provisions are retroactively effective to March 1st, 2020. And I'm going to send that along to Tori as well. And that's my update. And thank you very much for having me.
Great. Thank you, Craig. Do we have any questions for Tori or Craig from the federal office? All right, hearing none, I will ask if Sarah Brinkman from Stratus Health is here, or RQITA.
I am, and I have an almost a sweet baby, so I apologize in advance for any squawking. I just have a few quick updates for you all. We have an MD-Quit BKG coming up in June, and I had the date in front of me a second ago and I lost it, so I'm going to pull that up. Just a reminder that that's forthcoming. We do anticipate that BKG will focus in part on your QI projects and preparing for the launch of those. So please plan to attend if you are able and come with your ideas. June 10th is the date. And I can also post the registration link in the chat for you all when I'm done speaking here. Another thing I'll drop in the chat is an updated star rating resource that was just finalized and posted for your reference, talking about the changes to the methodology. Sorry. Asher wants to say hi. Some updates to the methodology related to the star ratings and impacts that that's having on some critical access hospitals and hospitals in general. So I'll post that resource. And then the final thing is just a plug for you all. We did, in the most recent edition of MD-Quit Monthly, put out a request for feedback from the critical access hospitals. That brings in a letter asking for their input about our quality time sharing pie podcast that we've been developing. Interested to know what folks think of that, if they would like to see us continue to develop that resource going forward, or other ideas that they have for how to utilize the expertise we have available to us in the form of the virtual QI mentors. So if you are in touch with your hospitals directly through webinars or through technical assistance provision or anything like that over the coming months, if you could gently encourage them to check out that first article in MD-Quit Monthly this month, we really would appreciate their feedback. We're getting ready to launch the second nomination and application period for the virtual QI mentors. Our first group is coming up on the end of their 2-year term. And so we want to get feedback from the field to be able to inform what we do with that program going forward. So I will drop the link for the MBQIP BKG registration and the star ratings resource in the chat. And if you have any other questions, let me know. But I will yield my time to Maddie at FMT.
Awesome. Thank you, Sarah. If we have any questions for Sarah and the RQITA team, please do type those into the chat box. Nicole, thank you for putting that resource related to the star ratings in the chat box there for us. Maddie from the Flex Monitoring team.
Hi everyone, this is Maddie. So FMT has been pretty busy. We are approaching the end of our project year, which ends in June. So I have a number of updates on things that are posted on our website and things that you can check out. In April, we held a webinar presenting our findings about the CAH response to COVID. So the slides and the recording for that are available on our website. And then we've, in the last 2 months, we've released several different policy briefs, both related to COVID and on other topics. So the COVID briefs include CAH partnerships during the pandemic, innovations and workforce challenges for CAHs during COVID-19, and promising flex program initiatives to support CAHs during the COVID-19 pandemic. And then some of our other policy briefs on other topics include rural initiatives addressing community social needs, monitoring state flex program financial and operational improvement activities, and evaluation of the use of CAH cohorts for quality improvement activities. And just earlier this week, we released the CAH Financial Indicators Report. We've also released several updates to Compass for financial data, and the quality data updates will be coming soon as well, probably in the next couple weeks. And then we are continuing work on some of our projects for this year, including evaluating EMS supplemental grants, examining the effect of system affiliation on CAH financial performance, and reviewing lessons learned from state and federal demonstrations and initiatives to support rural hospitals. And then sort of my last preview, I guess, is that we're looking forward to our proposed projects for next project year, which begins July 1st. So we have a number of projects planned for that. I'm going to list them just so everyone knows, but it's sort of a mouthful, so bear with me and feel free to ask questions if you want to know more about any of this. But some of our projects will be supporting CAHs and CAH staff during the COVID-19 pandemic, quality improvement data collection, next steps for the Flex program after COVID-19, evaluation of the EMS supplemental funding and EMS agency licensure requirements, financial and community characteristics of CAHs participating in value-based care, CAH engagement in multi-sector community networks, use of translation services in CAHs, and best practices for cancer care models in CAHs. So those are all of my updates. All of our publications and the webinar I mentioned can be found on our website, and you can check out those Compass updates as well.
Awesome, great. Thank you, Maddie. Thank you, Flex Monitoring team, RQITA, and the federal office. Do we have any questions before we get to our presentation topic for the day, which is supporting new models and payment and delivery care? All right. Hearing none, I will ask if Mr. Pink is here from the Flex Monitoring team.
I am.
There he is. Howdy, George. Thank you for joining us and welcome.
Okay, thank you, Caleb. I greatly appreciate the opportunity to talk to you today. I'm going to give you a brief overview of the proposed new model called Rural Emergency Hospitals. I'd like to show you some preliminary data that we're putting together. And then finally, I'd like to seek your feedback on as we try and estimate the number of hospitals that might convert to REHs. So this is a research project. And that is the context of which I'm going to be presenting this data. We do have a research objective, which I will tell you about in a few minutes. So I think just because some of you may or may not be familiar with REHs, I just thought I'd briefly go over what it is. It was proposed in the Consolidated Appropriations Act of 2021. Basically, it's a new Medicare payment type. that to fund a new type of facility that provides ED care only, observation care, outpatient services, and an optional SNF care in a distinct part unit. REHs do not provide acute care inpatient services, and all the regular emergency caveats such as EMTALA will still apply. And importantly as well, that REHs can be originating telehealth sites. There is a process, an application process, and eligibility requirements. Again, I'm giving you sort of the high level overview. There's a lot of detail that presumably will be forthcoming about each of these. But critical access hospitals and rural hospitals, PPS hospitals with less than 50 beds or less are eligible to become an REH. There are 4 requirements in the application to become an REH: an action plan for initiating the services, a list of all the health and other services that will be provided on an outpatient basis only, information about how the additional facility payment will be used. I'll talk about that in a second. And then evidence that the REH will be able to obtain state approval of its licensure. There are, again, a long list of requirements. These are the most important ones, in my opinion. The average length of stay cannot exceed 24 hours. Just like any other ER, it must be staffed 24 hours a day, 7 days a week, but there are relaxed staffing requirements. So it could be a physician, nurse practitioner, clinical nurse specialist, or a physician assistant. It must meet Medicare licensure requirements and have all the staffing responsibilities of a regular ED. Very importantly, it must have a transfer agreement in place with a level 1 or a level 2 trauma center. Some of the ER docs with whom I've talked question whether that level is required, that a 3 or 4 level might be feasible as well. There must meet the COPs applicable to CH's emergency services and hospital EDs. And finally, if it decides to have a SNF, then it must meet the DPU requirements as well. The Medicare payment of an REH is this, the major component of it is this beast called a monthly additional facility payment. I'm not sure exactly where this method came from, but essentially what CMS will do is estimate the total amount that was paid to all critical access hospitals in 2019, then estimate the amount that they would have been paid if they had been paid under prospective payment. They take the difference between those two numbers, they divide that by the total number of critical access hospitals. That comes up with the average amount of CAH sort of reimbursement in excess of PPS. And that would be divided by 12, and that's the extra amount per month that an REH would get. I'll talk about that more about that in a second. Outpatient fees, the schedule is enhanced by 5%, so it would just be the OPPS fee schedule times 1.05. Patient co-payment is the same, the SNF is the same, the ambulance is the same, and the rural health clinic is the same as well. There are a lot of questions about the quality metrics. I think most people agree that this new kind of facility will require unique and perhaps new types of quality metrics. They'll be made public, they'll be posted on the CMS website, and then CMMI will also be required to evaluate the impact on quality and access to healthcare at 4, 7, and 10 years. What has been the reception so far? I think the optimists, the glass half full people, this is based on maybe 12, 14 people with whom I've talked. It could be a real alternative for communities facing hospital closure. If the alternative is nothing or an REH, there could be communities that would certainly prefer an REH. Pessimism maybe is too strong a word. Skepticism might be a better word. And there's really 4 or 5 things that people are most concerned about. There's no mention of capital in the legislation. Some of the people with whom I've talked who run these kinds of facilities in Texas, for example, say that there's no way existing hospital buildings are going to be usable for REHs. They're going to have to be, there'll have to be a new physical plant for these kinds of facilities. There are some parts of legislation that make one scratch one head. Like, I'm not sure, there seems to be confusion about why they would want a SNF DPU, which requires 24-hour coverage, but not have any inpatient beds. If you're going to have the 24-hour coverage, why wouldn't you have inpatient beds as well? Some of the biggest obstacles I've heard is community resistance. A facility that's open and running, that's got 150 FTEs, for example, to go to the community, say, guess what, we're replacing it with an REH that has far fewer FTEs. That may be a challenge. And then finally, the size of the monthly additional facility payments, is that going to be enough or not? And just to give you an example, this is based on the NRHA example that they've posted on their website. I sort of updated it a little. But CMS estimated, MedPAC estimated that CHs were paid $14 billion in 2019. In 2015, I updated that. And so if we estimate the PPS payments would have been 11 billion. Again, that's based on the Congressional Budget Office that said CHs on average are paid 25% more. Just do some simple arithmetic. I estimate really, because this is a half-baked, back of the envelope kind of calculation, $2.2 million would be the extra payment. Is that going to be enough to induce CH to convert to an REH? I do not know the answer to that. So the research that we're involved in is really a policy question that the Federal Office of Rural Health Policy has asked us to look at. REH is a new Medicare payment classification. I can't remember any other new ones for a long time. But the number of rural hospitals might actually convert to this is unknown. So they've asked us to take a guess at trying to estimate the number that might convert. Again, the 12 to 13 people I've talked to, I've heard everything from 0, basically saying there's no way an ongoing CH would be interested in this model. And I've heard upwards of 100 or more people, several people estimating there could be up to 100 that might convert. So the policy question we're trying to answer is how many rural hospitals might convert to an REH. So my hypothesis, and please feel free to attack this, I'm an academic, I'm used to a lot of criticism, that's good. Financial and operational measures of closed hospitals have closed in the past 10 years, may be predictive of rural hospitals that are likely to consider conversion to REHs. Several commentaries on the legislation have said that this model is directed at communities where there is a high likelihood of a hospital closing, and this could be a viable alternative to an inpatient facility that's closing. So what we're doing, I'm going to show you some data in a minute, is I've selected some measures of closed and financial and operational measures. We've compared the closed hospitals to open hospitals. And I try to identify some of the variables where there are big differences. And we will then hopefully use these measures to predict hospitals that are likely to consider conversion. So let me show you some data, what we found so far. So those of you who are familiar with our closures website will know that we have two different kinds of closures: complete closures and converted closures. So complete closures are hospitals which no longer provide any healthcare services at all. I mean, they are literally a parking lot, an empty building, whatever. There's no healthcare provided. Converted closures are facilities where there's no longer any inpatient care provided, but they've morphed into some other kind of healthcare facility, such as urgent care, primary care, outpatient clinic, in some cases a rehab facility or long-term care facility. And then the third column on the right are open hospitals. Those are all the hospitals that we found to be open on December 31st, 2020. So all I'm doing here is comparing a variety of financial and operational measures of the complete closures to converted closures to hospitals that are currently open. And the data that are highlighted in yellow are the measures that we found to be most different between the hospitals that closed and the ones that are remained open. So 3 years in total margin, less than 0%. So that's what I call sort of long-term unprofitability. The same with 3 years operating margin. Much higher percentages of the closed hospitals have long-term unprofitability. Average daily census, acute and swing beds, less than 3 per day. Again, much higher percentage in the closed than in the open hospitals. And then net patient revenue less than $10 million. So these are by far much smaller facilities. Now this is kind of a misleading number because the net patient revenue is spread over 2011 to 2019. So they're not really constant dollars, but I thought, just the magnitude of the difference between, and I'll show you the medians in a second, the magnitude of the difference tells me that these are smaller facilities. Interestingly enough, the closed hospitals are less likely to have an RHC and less likely to be government owned. I'm not sure what to make of that. Amongst hospital types, there's no question that a higher proportion of closed hospitals are PPS, a lower proportion are critical access hospitals, and a higher proportion are Medicare dependent hospitals. Everyone else is more or less the same. In terms of geographic location, there's no question that closures are predominantly a South Census Division phenomenon, although there are some in the West North Central as well. So here are the medians values of some of the different groups. Again, you can see the total margin, operating margin. This is the year that they closed. Was highly negative for both of these types of hospitals versus positive for the open hospitals. Again, the net patient revenue, less than $10 million for both types of closures versus 23 million median for open hospitals. The rest of the factors, outpatient revenue, Medicare inpatient, inpatient, outpatient, uncompensated care, Medicaid, distance to closest hospital, I didn't see the huge differences here. I mean, there are slightly less dependency on Medicare for outpatients, slightly more uncompensated care, but these were not, huge differences in my opinion. Okay, so here's where I would really appreciate some feedback. This is sort of a quick overview of REHs. What I would like, if you could type your answers in the chat box, I would greatly appreciate it. I would just like your opinion about, given what is known about the model to date, what I've told you now, what you know about it yourselves, what do you think are the types of rural hospitals that are most likely interested? And if in this case, you want to talk about critical access hospitals only, that's fine. To be interested in conversion to REHs? Are they, financial distressed? Are they ones with low average daily census, a low amount of net patient revenue, and so on? So if you could just take a few minutes and type in your answers in the chat box. I will not attribute any of your answers to specific individuals, but what I will do is I will count up at the end of everybody's responding. I'll count up the number of responses and this will be important input for our research process. So I'm just going to give you a couple of minutes to give me your answers, and that would be greatly appreciated.
I will. I do want to draw your attention, George, to one comment that came in before you asked for this, and that is that the rural emergency hospital model would not be super helpful for Alaska critical access hospitals, but we do have a lot of interest from the few FQHCs that do a high rate of emergency care, over 50 transports per year to a level 2 trauma center, and are operating 24/7 staffing. They benefit from the designation to a higher reimbursement, as well as allowing EMS entities to bill for transportation to that REH, as opposed to not being able to bill to an FQ.
Yeah, so that's an interesting comment. I don't know if anybody from FORHP is still on the call or not, but my understanding of the legislation is that only CHs and PPS hospitals under 50 beds are eligible to apply. I don't think FQHCs are yet, are they? I stand to be corrected. Tori, do you know?
Hi, George. So under our current understanding of the legislation, it is only hospitals like critical access hospitals or small rural PPS hospitals with 50 beds or less that would qualify to convert to this type, essentially shutting down their inpatient facilities, maintaining that 24-hour emergency department and outpatient facilities with the potential for a skilled nursing facility also to be in the mix there. So again, we believe that the congressional intent was for a rural hospital that was on the brink of closure, that this would be an option for them to maintain services in their community without having to shut down everything.
That's my understanding.
So would a closed facility be able to open back up as a emergency hospital?
It is the impression. We are still getting the final rules from the congressional intent with our lawyers to figure out exactly what the timeline is. But per the enactment of the consolidated budget from December 27th of 2020 to the start point of January 1st, 2023, if a facility were to close during that point in time, they would be eligible to convert to the new hospital type. Now, previous closures is still under consideration. There may be some leeway that is granted to hospitals that have closed in X number of years in the past that could reopen as an REH, but we have no set timelines on that yet.
John Suplet is putting something in the chat that says differently.
I think,
well, it's not different. It's a nuance. What Tori has said about a grandfather provision is not in the law, but it could be in the rule.
Great, thanks, John, for that clarification. We have yet to make any hard and fast rules. I would be on the lookout for CMS OPPS rule for 2022, hopefully being released in late June, where they're going to be asking for a whole host of comments from stakeholders, and having that feedback from rural stakeholders will be critical in the rulemaking process.
oh, could you, average daily census, I believe, is what ADC stands for, is that correct?
Yes,
Mr.
I'm
Green?
sorry. ADC stands for average daily census.
And thank you guys for typing your answers into the chat box. We were excited about this to be able to provide George some feedback. So please do continue that. Given what is known about the REH model to date, what types of hospitals are most likely to be interested in converting? We have a list of options.
Caleb, if you tell me when the chat box has stopped populating, I'll conclude my presentation.
Absolutely. It seems to be slowing down, but I will push for one last call. Anybody who's not had an opportunity who might have some thoughts on which of their hospitals that you know of might be interested, or which would be most interested in converting.
Oh,
right.
Caleb, this is Dorothy. I had a random question. Would a financially distressed COB be able to open an RHC while also converting to an REH?
I don't know
would
the answer to that, Tori.
The resources?
I mean, there's no set rule against it right now. my thought process. We do know that these facilities are going to be encouraged to continue outpatient services, potentially in the form of an REH, but they would, be separate from the REH facility. So potentially the rural health clinic could be related to the facility, but again, it would be paid separately using the the rural health clinic models for payment, and not directly tied to the facility, since the facility would no longer be an inpatient service. So to answer your question, currently there's nothing that would prohibit it from opening a new rural health clinic to support those critical primary care services in that community.
Awesome. Thank you, Tori. Thank you, Tori, for helping answer some of those regulatory questions. And as you guys have those questions, or your hospitals who are starting to examine these new payment models have questions, please do let us know, and we can filter those to the appropriate person. All right, George, I think that is all of the comments we're getting in the chat box. If there are any other questions for George, I encourage those to be asked now, and we'll be around for a little while as well. Go ahead, George.
Thank you, Caleb. Just to conclude, well, first thing is I'd like to ask Tori if she would like to start co-presenting with me, because she gets to answer all the tough questions and I can just sit back and watch. But the major—
Anytime, George.
What you've just told us will help us determine the potential number of rural hospitals that might convert to an REH. We're going to write up the results in a findings brief, and that will be distributed and presented at the next meeting of the National Advisory Committee on the Rural Health and Human Services in June. So I would again like to greatly express my appreciation for your time and giving us some feedback. It will be very helpful. And with that, I will step aside. Thank you.
Thank you, George. All right, Mr. Supplett, I know you're here somewhere. There we go. Oh, you muted yourself when you started your camera, John. You're still muted.
Great. Can you see my slide deck?
We can see your slides and hear and see you.
That's wonderful. Well, thank you very much for inviting me to present to you this afternoon. Many of you don't know me. I'm John Supplett. I'm the Senior Director for Rural Health Services at the American Hospital Association, which makes me the rural guy at AHA, and I'm the generalist. So I work between the membership, which are the hospitals who are represented by the CEOs. So there's some 1,860 hospital members of the Rural Health Services segment at AHA, and with our staff, who primarily are the representation and advocacy experts, the lobbyists, and the policy and rulemaking folks in the Washington office. And my role is really to be an intermediary between our hospital members and our staff. So one knows what the other is doing and why, and one knows what the needs are for representation and advocacy and why we take the positions we do. So that's, in a nutshell, my role as this segment director for Rural Health Services. So today, what we're talking about are new models of rural health payment and delivery. And the reality is that there's been new models and innovative models of payment and delivery that have been coming out for a decade. Through the ACA primarily, but also through the field. And the evolution and the number of these models has increased considerably under COVID, as COVID has served as a catalyst for innovation and for looking at ways to restructure the way we deliver care in a more cost-effective manner. And what all this rolls up into are value-based initiatives that represent opportunities for rural healthcare providers, rural hospitals in this case. And so what I'm going to do in the period of time that I have is share with you some of the highest profile models of payment and delivery that have come forward either through CMMI demonstrations or through the field, and what those opportunities represent for rural hospitals and providers. So I will begin. Move some stuff here. With this slide from CMMI, and what this really represents is when you look at value-based initiatives and the opportunities for rural hospitals, they tend to cluster into these four categories from CMMI: bundle payments, primary care, initiatives to accelerate development and testing, and then accountable care. And you can see the descriptions, and on the right-hand side in green are those innovative models that are still active. So BPCI is still active, Frontier CHIP has been reauthorized, REACH has been reauthorized, Accountable Health Communities is still active, the CHART model is active and evolving, global budgets are active, and the next gen ACO model. And all these are relevant for rural hospitals because rural hospitals are participating in each of them in some form or another. But when I pare these opportunities down, really I'm going to focus on the ones that I think are really most dynamic opportunities for rural. And that begins with the Accountable Health Communities model. And what this is, it's a study that CMMI has put together to look at the critical gap between clinical care and community services. So this is a study, not necessarily a delivery model or payment model demonstration, but a study that they're conducting to test whether they're systematically identifying and addressing the health-related social needs of beneficiaries and the impact that they have on the total healthcare costs and the ability to improve health and quality of care. So strong elements of social determinants of health throughout this study. The foundation for this model is universal comprehensive screening for health-related social needs. And the model aims to identify and address beneficiaries in at least the following core areas: housing instability and quality, food insecurity, utility needs, interpersonal violence, and transportation. So under this study, those are the areas that are being investigated. To fulfill the requirements of an accountable health community model, you have to identify and partner with a clinical delivery site. Primary care clinics, behavioral health providers, and hospitals are examples to conduct these systematic health-related social needs screenings of Medicare and Medicaid beneficiaries, and then make the referrals to community health services that may be able to address the beneficiaries' needs. The next step is then to coordinate and connect high-risk beneficiaries to community service providers through a community service navigation process. So these community models have their own navigation process. And then to align the model partners to optimize community capacity to address these social needs. And for those that are participating, they're doing it over a 5-year period to test a 2-track model featuring interventions of varying intensity. The first model is the assistance track, where you provide community service navigation services to assist these high-risk beneficiaries with accessing services locally. And the second is the alignment track, where you encourage the partner alignment to ensure that community services are available and responsive to the needs of the beneficiary. Now, to be eligible for participation, the minimum number of beneficiaries that applicants are required to screen annually is 75,000. Okay, so it's 75,000 Medicare beneficiaries screened annually in order to be eligible to participate in this demonstration. So that means we're talking about sizable communities that have or service providers that have large market areas, and that really takes a lot of our providers out of the equation. But there are a couple of examples that I'll share with you with mixed success. And the first is Tift Regional Health System in Southern Georgia. This is the flagship hospital of Southwell, which is a leading non-for-profit healthcare system that's serving South Central Georgia. And TRMC is a 181-bed regional referral center. It is rural and it is large, and it offers comprehensive services and multi-specialties. Now, they participated in this AHC under the assistance track, that is the community service navigation services to assist high-risk beneficiaries with accessing services. And to do so, they employed 2 navigators, 6 screeners whom worked from their clinic site, and other than the anticipated fits and starts with some CMS screening software, they were able to integrate pre and post-visit screens into their workflow. They gathered and reported their findings, and they identified housing, food, and transportation as areas of needs, but also in this study, They also identified purchasing prescription drugs was a major need for their community. They collaborated with local churches and civic groups like the United Way, but the community lacked the capacity to meet the need, and the study did not allow providers to fund services. So in other words, the demand for services that were identified through the screening with respect to housing, food, transportation, and prescription drugs was greater than the capacity that existed in the community. And under the study, TIF was not allowed, the participants are not allowed to subsidize or fund those services. So as a result, they had to withdraw from the study moving forward. This is a county of 67,000 people, so the notion of an annual screen of 75,000 beneficiaries was also a milestone that they couldn't hit. And then when they compared their findings from the study to their community health needs assessment, it didn't really reveal any new areas of need, but it did validate them. So in summary, it was the lack of local infrastructure and the capacity to meet those needs with existing resources that forced TRMC to pull out of this demonstration. So here's another example of an accountable health community demonstration. Now this is Ballad Health, which is a large integrated healthcare system that serves 29 counties in Appalachia, Northeast Tennessee, Southwest Virginia, Northwest Carolina, and Southeast Kentucky. And a recent merger created the synergies necessary to address this regional population. Well, to formally address the social determinants of health within the HC model, Ballad was funded through the CMMI designated assistance track, which then facilitates the community service navigation services to help these high-risk beneficiaries access services to health-related social needs. And under this model, they hired 9.5 FTEs that were paid directly from the cooperative agreement through CMMI, including 1 program manager, 1 screening and referral specialist, 1 data analyst, 1 lead navigator who managed 6 full-time navigators. And then these 6 full-time navigators whom were familiar with the community health workers, if you will, who they serve and often personally knew the beneficiaries that they were screening. So within an annual budget of $500,000, all of which came from CMMI's cooperative agreement, Ballad screens for unmet social needs and then navigates the rural beneficiaries to those appropriate social services. And after nearly 18 months, they completed 49,500 screenings, which resulted in 4,900 beneficiaries that were eligible for navigation. What Ballad did differently was they created a preferred community resource network that currently consists of 12 organizations that have provided excellent service within this partnership. And half of these were faith-based organizations. So Ballad Health also established a patient assistance fund to provide limited financial supports to beneficiaries in need. So you can see where, because of their resources, they were able to do some things that were a little bit more progressive with the new network and the financial support fund, patients assistance fund. They didn't use the CMS software. They created their own data system, and while doing so, it added an investment for Ballad Health, but they were able to report their data systems and increase speed and flexibility. So in this example, it worked, but it worked because of the depth and breadth of the resources that Ballad had and their ability to coordinate and organize services to align on that assistance track, and the navigators then could refer to the social providers in their community. The next example I want to talk about is hospital at home, which again is sort of an ongoing Medicare demonstration. Johns Hopkins established hospital at home in 1994, and the goal was, which was sometimes called the virtual hospital, was to avoid hospitalizations and manage these higher acuity, higher risk patients within their own homes with hospital standard care. But in March of 2020, at the beginning of the surge of COVID, CMS announced its innovative Hospital Without Walls program. And then in November, during that peak, CMS will also announce that it would reimburse acute care providers for hospital at home as part of its new acute care at home program. And this allowed for regulatory flexibility for hospitals then to deliver inpatient care at home while still receiving hospital payments. Well, under COVID-19, of course, it allowed then hospitals to free up beds and then protect vulnerable patients. Many hospitals were sending patients home. So acute level patients received a self-monitoring kit that they brought to them at home that included a pulse oximeter to measure the heart rate and oxygen uptake. And each day they would get multiple calls to check in on their vitals or a virtual doctor's appointment and a daily in-home visit from a paramedic that could include an EKG, lab tests, and such advanced treatments as IV or respiratory therapies. And patients could be identified for a hospital home program upon presentation to the ER by their primary care physician or while an inpatient. And evidence showed that the hospital home program did produce better clinical outcomes, it improved patient satisfaction, and it reduced the cost of care. Well, Albuquerque's Presbyterian Healthcare Services launched its hospital at home program back in 2008. And this is a large integrated system with its own health plan. It offers hospital at home as a benefit to its health plan members, including those that are participating in Medicare Advantage plans. And it has treated more than 1,300 patients under their models. And daily census averages between 1 and 2 patients a day. And in a study that was published in Health Affairs in June of 2012, their hospital at home program found it delivered 19% lower costs than inpatient care. So hospital at home works. It works because of the flexibility that's provided to the providers currently under the National Public Health Emergency, which we would like to see continued because it does allow the flexibility for the patient to receive care in an environment which suits their needs, but also at the level of care that is a hospital standard. The tricky part for rurals is time and distance. It's one thing to be able to demonstrate a hospital at home in an urban environment where community health workers and ancillary providers need only 15 minutes to travel from their hospital to a patient's residence. That conversation becomes much different when you're looking at rural communities, particularly frontier rural communities where you're traveling 30 minutes or longer in order to reach a patient's home. So that's a limitation of making this work in a rural environment. Also volume. So while you don't anticipate a large volume for these options, you do need volume to make it worthwhile for the number of staff that have to be dedicated to this model of delivery. So it does offer a lot of hope and opportunity, and it's certainly something that's going to continue to move forward and evolve very quickly. This case example puts it all together. As of 2019, Keystone Accountable Care Organization, which is in Pennsylvania, serves about 78,000 attributed beneficiaries in primarily rural areas of Pennsylvania. Now, this ACO is a joint venture that's consisting of Geisinger Health System, which is central Pennsylvania, 2 independent hospitals, a graduate medical education organization, and then a collection of independent physician practices. And the organization has a patient-centered medical home recognition for its primary care practices. So it does pursue certification through NCQA. Well, in 2013, Geisinger began designing its program to improve patients' health by addressing social determinants of health and clinical needs. And they sought to address the non-clinical care gaps in the 5 following areas. Well, the same as the accountable community health program: housing, stability and quality, food insecurity, utility needs, interpersonal violence, and transportation. And Geisinger envisioned having community health assistants or community health workers identify and address these needs by conducting home visits and coordinating within community organizations. So this began not as an ACO or as a hospital at home, but as an accountable community health program. with the CHAs being the heart of the Navigator program. Through home visits and then follow-up phone calls, the community health assistants helped identify beneficiaries' clinical and non-clinical needs and triage them to the beneficiary's primary care team and community resources as appropriate. Well, then it was about 2 years ago when Geisinger launched its novel delivery model called Geisinger at Home. So this predates COVID, and it moves comprehensive care upstream into the homes of this dependent population, working closely with patients' primary care physicians, a team of doctors, nurses, and dietitians, and they can address the medically complex patients where they live. Well, Geisinger's program is longitudinal, so it starts with a comprehensive in-home assessment and care plan and coordinating with the primary care providers as needed. And they report results that have been dramatic. For more than 5,000 patients that have been enrolled in this program, they've seen a 35% drop in emergency department visits, a 40% decline in hospital admissions, an average annual reduction in spending per patient of almost $8,000, and more important for patients is their improved quality of life. Now, George has gone through the rural emergency hospital demonstration, which of course is another model of payment and delivery that would be available beginning in January of 2023 for what you're identifying as frontier low volume critical access hospitals that would convert to a freestanding ED, more or less. But it's not the first example that exists out there, and someone had actually put in the chat box the experience of a hospital that closed, that became a freestanding ED by basically transferring their Medicare provider number to a larger nearby hospital. And that's exactly what happened with Piedmont Mountainside Hospital and their emergency services. It was in January of 2016 that Atlanta-based Sunlink informed its community that it was going to close North Georgia Medical Center in LLJ, Georgia. And so the Gilmore County Board of Commissioners expressed their skepticism, and they sought assurances that the medical facility would remain open. They believed that the best that county residents could hope for was to have an emergency department opened year-round. And as a community-focused hospital, Piedmont Mountain Hospital recognized their immediate need and acted upon it to expand its services in Gilmore County, which was only 20 miles down the road. And it delivered the same level of patient-centered care under the Piedmont name. Now, patients in LOJ requiring admission or transfer will follow the same process as they would if they were entering PMH's emergency room in Jasper. And since opening the ED, it averages over 30 patients a day. And in their first 6 months, they had seen over 5,000 emergency visits. And additionally, PMH then is working collaboratively with the local Gilmore County EMS and ambulance service to ensure that patients are transported to the most appropriate facility for their patient care needs. So help me out with time here, Caleb, if I'm going long, getting me a heads up, all right?
Yeah, you got all kinds of time.
Okay, all right. I don't have that many slides, but I think you're getting the sense of how these innovations are coming forward in different forms and fashion, and how they come from either CMMI innovations or actually from the field. This next example is also sort of everything together, but it doesn't happen overnight. In this case example, Northeastern Vermont Regional Hospital established what was supporting hospital at homes, but it bears repeating. In this case, they use the community health worker or promotora as a trained liaison who mediates between the healthcare and social services in the community. Of course, they are from the community. They possess a deep understanding of the culture, the socioeconomic status, and the life experiences of their residents. An example of community outreach and population health was established almost 20 years ago by Northeast Vermont Regional Hospital. 20 years ago, before the term social determinants of health was even coined, our rural hospitals were already dabbling in delivering that kind of care. In 2002, it was at the request of physicians from the hospital to engage community members to assist in helping their patients manage food, transportation, housing, and life skills to improve their health and well-being. And the program evolved to become the Community Connections Team, or COCO, that gained traction in 2007 as part of the larger Vermont Blueprint for Health. And the Blueprint is a statewide program that calls for primary care practices to serve as medical homes with comprehensive support from community health teams. So the Blueprint really was building much upon the experience of Northeastern Vermont and its community health workers, but at the same time trying to expand that across the state as an with an integrated information technology infrastructure that you can see then in this Venn diagram. Well, a study showed that in 2013, that the estimated total program cost was about $420,000, of which $285,000 was for personnel and the balance of $135,000 for operations. They reported that inpatient use and per person per month costs decreased 21 and 22% respectively, that ED use declined 31%, and associated cost per person per month fell 36%. And the overall use and cost per person per month dropped from 9% and 11% respectively. So once again, demonstrating that the combinations of these experiences and innovation for models of payment and delivery really are delivering at the community and local level for rural providers. The other theme that you're hearing throughout these examples is that you can't go it alone. It's important to recognize the growth of affiliations that is taking place. And over 51% of rural hospitals are affiliated with healthcare systems through ownership, lease, or contract management. And from 2005 through 2016, there were 380 rural hospital mergers. And Kaufman Hall did a study. They found that mergers have been a common phenomenon among rural hospitals. Approximately 12% of all rural hospitals merged between 2005 and 2016. And then in 2020, Kaufman Hall reported that 24%, or 19 of the 79 transactions announced in 2020 involved either rural or urban rural sellers. This phenomenon is not going away, and with COVID, it in fact is expected to increase. But affiliations don't require an asset transfer. And as you can see on this slide, there are multiple ways in which a rural hospital can affiliate with other providers in their communities. Building resilience in a post-COVID environment is what's going to drive these decisions moving forward. And it's this emphasis on resiliency that will bring a greater focus to what core business activities will drive the future direction of hospitals and health systems. And the organizational leaders of these affiliations will have a hard look at underperforming service lines and facilities to determine how much they contribute to the overall enterprise. The only comment I can make here for my rural hospital providers is you need to be the best value provider at the service you provide best. You need to be the best value provider at the service you provide best, because as we continue to look towards greater affiliations, not necessarily asset transfers, it's what you bring to the table and how well you do it that will be scrutinized by the group. A great example of these affiliations and the truth that an asset transfer is not required is Wilderness Health. And this is a not-for-profit collaborative of 10 independent hospitals and additional clinics working together to improve healthcare in northeastern Minnesota and northwest Wisconsin. It was founded in 2013, and it brings smart strategies such as shared services, quality improvement, and an ACO, because Minnesota has a Medicaid ACO, to their rural health system. And it provides about services to approximately 450,000 people in this market area. Together, they have achieved a great deal, from roundtables with department heads up to and including creating their own ACO. And you can see a list of their achievements right here on this slide. And another example of affiliation comes from Quincy, Illinois, where Blessing Health System is an integrated health system And for those not familiar with the area, you can see the map there, and it's across the river from Hannibal. And it serves the Illinois, Iowa, and Missouri tri-state area with a web of 3 hospitals, 2 physician group practices, an accredited college of nursing and health sciences, and a network of medical specialty businesses and a charitable foundation. Blessing itself employs more than 3,500 people in almost 150 locations, including a 29-bed hospital in, a 229-bed hospital in Quincy. Quincy is a big, small town, and so it has that capacity. But then it also has a 25-bed critical access hospital in Pittsfield, and then a 42-bed hospital in Keokuk, Iowa. So why, I mean, there's a lot of systems out there, right? So why Blessing? But why not? When you look at this sort of profile of Blessing Health System and its location in downstate Illinois on the Mississippi River, proximate to Iowa, Missouri, and rural Illinois, it is very much a rural profile. But the bigger question is, why Keokuk? And control of the Keokuk area hospital in southeast Iowa will be transferred from the current parent company, which is Unity Point of West Des Moines, to Blessing in Quincy. It's going to be transferred, not sold. And that was effective March 1st. It's considered a member substitution. And Keokuk Area Hospital has struggled over the past several years, as of course have many rural hospitals. Well, Blessing thinks there's 2 steps in restructuring the organization and in strengthening its financial position, and that's reopening the Keokuk Medical Clinic, which is the physician practice Blessing formerly operated, and then enhancing the care available through the hospital's emergency room. So that's the relationship between Keokuk and Blessing, and if you will, Pittsfield and Blessing. But for Blessing itself, it's participating in its own hospital at home model with Brigham and Women's Hospital in Harvard in Boston. Again, it has its accredited nursing school, and it's member of this larger BJC collaborative across central Illinois and Missouri. Collaborative, again, not transferring assets, but collaborating with those institutions you see starred on that map as part of this larger system. So Blessing is both affiliating with smaller institutions while affiliating with larger institutions in order to achieve its goals of delivering care through new models of payment and delivery. So those are the examples I brought to you this afternoon. There are dozens more. You can take them in a number of different directions. But the reason I brought these to you because these are the ones that the value-based initiatives that are offering the greatest opportunities for rural hospitals and providers. And CMMI has given us these glimpses into these demonstrations through these advanced payment ACOs, the payment bundles, cost-based targets, Medicare certifications, the global budgets. We now have the chart model as an option that's available to us in the next coming years. And we come to understand the challenges we face providing care in rural America. But there are a few central themes to consider. First, value-based initiatives and the ability to manage 2-sided risk is the foundation for future payment models. And rural hospitals have to be adept with value-based purchasing as fee-for-service becomes an increasingly smaller part of their revenue streams. Second, managing risk means managing population health, which our hospitals have demonstrated they can do very well. So rural hospitals will need the technical assistance and support from collaborators across the community to screen high-risk patients, navigate proper levels of care, address these social determinants of health, and then deliver standard hospital care at home. Third, managing risk puts greater responsibility on clinicians. Rural hospitals are quickly adapting to telemedicine and then engaging nurse practitioners, physician assistants, certified midwives, and community health workers, and others who are essential to meet the demand and manage costs under a value-based initiative. And fourth, you cannot go it alone. Size and scale matter. One has to be the best value provider for the service they provide best. And fit that piece into this larger payment and delivery model puzzle. So I'll stop there, Caleb, and be glad to take any questions or any conversation.
Awesome. John, thank you for that. I think there's a ton of great examples there. And I know from our previous discussion, like you said, you have a bunch more of examples if people have questions or would like beyond those great examples. We had one comment from Jill come in early on in your discussion or presentation, John. She said she'd found out that that ED visits had been down at a critical access hospital due to plans prescribing medications, health plans prescribing medications. She's assuming that health plans were conducting telehealth services to their members because they wouldn't just be prescribing medications without providing some sort of visit.
I would say that's a fair assumption.
Yeah, but I think that's really interesting, Jill, and I don't know that I've heard anything.
Well, and I think when we look at telemedicine, and I didn't go into it intentionally because we know about it, we know it works, our folks are getting very adept at it very quickly, but as are others as well. And, you know, the reality is that it's out there and it's going to remain. And there are ways to address that. I mean, it's hurting critical access hospitals, Jill, but is it helping the patient? And that has to be at the center of everything that we do. And I think the experience that many are finding is that the patient has greater access to primary and specialty care through telemedicine than they did in the past. There's a lot that has to shake out with respect to how telemedicine moves forward and who pays for it. But you know, we have to keep the patient's consideration in mind as well.
But one of the things I recommended, and I didn't get that directly from the call, it was from our hospital association, but for them to do telehealth services themselves.
Oh, absolutely.
And I had another question though. And I raised my hand. Is it okay to ask?
Oh, absolutely. Please. Yeah. Questions and comments now, please.
When you were talking about the accountable health communities models,
right?
What's going on in Arizona is that Health Current, which is our health information exchange, is partnering with, you may know who it is because they're from Chicago, NowPow. Have you heard of them?
No.
Okay, well, they're setting up a whole social determinants of health referral system on a website. And it is linking to our health information exchange for the hospitals to use. That's also linking into their electronic health records.
Right.
So they will be able to refer all these services out. And my question is, how does this tie into the alternative payment models, or does it?
Well, it all goes back to managing risk. And I think there's others who are online that will validate that. If you are simply getting paid under fee for service, then none of this makes any sense to you, and there's no reason you should pay attention to it. But if you are going to end up managing risk in some form or another, and that means by being affiliated with a system that's managing risk, either through an ACO, and given that many states already have Medicaid ACOs, there's many systems and hospitals that have to do this, Minnesota being the best example I shared today. You have to manage the population's health, and you have to keep them as healthy as possible and out of the hospital as possible, because those are the biggest costs in delivering care. And so that's where these community health models come into play. And the experience is that it's better holistically. It's better for the patient, it's better for the community. It has better outcomes, and it costs less. And that's the point. These are disruptive forms of delivery that are changing the way things are being done, that have been catalyzed under the COVID-19 pandemic. And they're not going away, because as we continue to see value-based purchasing and risk management roll out through our commercial plans, our Medicare and Medicaid plans, Medicare Advantage being the example, it's one that we're all going to have to be able to, it's an environment in which we all have to live. And Steve, you got your hand up too.
Yeah, hi, John. Nice to see you again today.
Yeah,
Uh,
Dave.
Sorry about that. I have two comments. One is I have some concerns about the lack of definition in terms of patient-provider relationship and or coordination of care as it relates to telemedicine services, and specifically with large organizations like a Cleveland or a Mayo or whatever, trying to expand their primary care footprint into other states and locations. Because what most of us in the critical access environment or rural America do best is primary care, which we want to continue to do and keep that local as we're trying to manage a population. The other component that I would comment on is that there's the financial risk piece that we're taking on in some of these advanced payment models does not line up with how healthcare is financed. So there's still an abundance of utilization or efforts to, from the payer perspective, manage what we're trying to manage. So they still are not getting out of the way. And until that really flips, which probably won't happen until we get to that global or capitated model, we're still going to be doing this dance of trying to balance, the payer's perspective and their desire to control costs. So that's going to have to change as well, I think.
Well, and again, those are very important points. And Caleb, you might want to actually dedicate one of your collaboratives or your learning experiences to this telemedicine discussion, because it is deep and broad, and it's coming like a freight train.
Yeah.
Absolutely. Thank you, Steve, for those comments and thoughts. Other comments, questions?
I just want to reinforce also, actually, it was what Jill said, and that's become an originating site for telehealth. And there's a lot of examples of rural providers who have done that. I didn't bring today, but they're very accessible in the media and through the journals. And what we're advocating for and what NRHA is advocating for is to eliminate the geographic limitations on serving as originating sites for telehealth. And rural emergency hospitals can be, and George pointed out, an originating site for telehealth. So there's your future. I mean, that's a must, as is affiliation in some form. You just can't go it alone.
Yeah, I think that's a good point. It reminded me of one of our upcoming learning collaboratives is focused on facilitation skills. We had one just recently focused on building and sustaining partnerships, but facilitating virtually is another opportunity that I think would be very beneficial as you're starting to have these conversations with hospitals about the importance of these models. And again, not necessarily encouraging every one of your hospitals to join an ACO or an advanced payment or a value-based payment, but at the very least, understanding that it's happening and that it's happening at an ever increasing rate. To John's point, it's been going on for a decade now, and more of these models are happening. I was on the phone with a flex coordinator earlier this week, and she said that all of her Medicaid within her state, Medicaid will be joining value-based care models or value care plans. And if you provide services to Medicaid patients in that state, you must join one of these 7, I believe it was, models of care. And you don't have to be ready and prepared for that, but it sure would be nice if you want to continue to provide some services to Medicaid patients.
And we didn't talk about global budgets in the Pennsylvania model and Maryland and Vermont through the Blueprint of Health, but those offer alternatives that would also fit into this value-based initiative format at the state levels too. And again, Jill, in the longer version of this, Copper Queen and the Douglas the closure of Douglas Hospital is one of the other examples I use for freestanding EDs. And Jim did a great job with that. And it's a great case example of how communities come together to meet a need.
That's the hospital I was referring to.
So we've got a few minutes left. We got just 3 minutes left. I'll ask Andy to put up the exit polling questions to make sure we're providing you guys with webinars that are educational and beneficial. Kyle, do you have a question?
No, I'm just always excited to hear more about how we can change the way we reimburse for healthcare, and I'm really excited to see what new information I can bring back to Wyoming, because we're really starting to look in a serious way on what we need to do for financial sustainability of our critical access hospitals. And so, John, I've always appreciated what you've brought to the table, and I hope that at some point maybe you'll bring something to Wyoming's table as well. Thank you.
Yeah, thanks.
Thank you, Kyle. I think it's a great point. I mean, for all of us who, when we began working in healthcare and realized that, wait, we don't do anything about the health and well-being for our community. It is episodic care. That seems a little odd and strange, but it is the model that we operate under. So trying to change that in a way to sustain providing care in our community, not just, wiping one slate clean and then hoping to build another one is a great point. And it is encouraging. And I think most people are really happy that we're starting to look at outcomes and starting to look at health and well-being of our communities in our payment models. As we have heard for decades, form follows payment. You will change your operations when payment changes. We will start to have population health and community wellness when payers start to pay for that. And payers are starting to pay for that in a lot more volume. There's so many more of these models with so many more participants now than there were a decade ago when we started talking about this. That's encouraging. But to Kyle's point and everyone's, it's difficult for especially these super small rural hospitals to transition like that when some of these models are geared toward, what was that model, John? 75,000 visits you have to have?
Yeah, for the accountable health communities, they wanted you to do 75,000 screenings a year. So that's a system, not a hospital.
Right. Yeah.
But that was for a study. The point was to show that the study that social determinants of health do in fact make sense.
Any other questions? I look through the chat box for questions and see unmuted microphones or hand raising, please do. I will remind everyone of the resources that will be coming out with the recording of this. We'll have John's slides, as well as I want to draw everyone's attention to a new resource or updated resource that Rural Health Value has, and that is a catalog of value-based initiatives for rural providers. And that was just updated to last week with the addition of a table that identifies HCP and land payment model types for all of the active programs. So that will be included with the resources and the recording for this webinar. I will thank Mr. Supplett and Mr. Pink, as well as our partner organizations for updates. But thank you guys so much for presenting and continuing this topic and conversation. It's continuing, and just because the chart model was postponed another year doesn't mean that conversation.
Yeah. Well, and thank you, Caleb, and hopefully I'll see some of these folks at an upcoming NOSOR meeting. Absolutely. All right, guys, give us a call or an email at task@ruralcenter.org if you have any questions. But have a nice day. Thanks, guys.
Thank you.